Hello guys, we are live now. Welcome to Health, Music and Fitness channel. Today we'll be discussing a few ECGs. They are exam oriented ECGs for medical students and health professionals and emergency medical specialists. And this is a very good collection of ECGs, so I'm sure you guys will enjoy. So we'll start, and like it says, the Bible says, if any of you lacks wisdom, let him ask of God, who giveth in abundance. So it is something like when we are ready, we'll get the wisdom, and it always comes through our teachers. And I give my credits and my regards to all my teachers from CMC and other places from whom I learned, especially regarding cardiology. Professor Annamani, MD in Medicine, Professor Jasveer Dhanova, MD Medicine, and Dr. TM Jason, Dr. Rakesh Agarwal, Dr. Thomas David, Dr. Rajneesh Kaldan, they are DMs in cardiology, and Dr. Professor PK Dandona, who was professor and head of medicine. And I'm very thankful to my teachers for giving me the time to grow and learn these things. And also the books which I have read for this, the Leo Shamroth, Hampton, Marriott, Goldman, and special thanks to ECGpedia for permitting me to use the ECGs for my book and the slides, and also special thanks to Google. So we will start, guys, and as usual I always start with this circle, and this is lead 1 at 0 degree, because without this you people will not understand. I'm talking to the medical students, not to the subject experts. So for them it is very important that at least 100 ECGs you should interpret, placing this in your mind and placing all the leads of the ECG on the circle. Then after sometimes your brain gets tuned to mapping all the things which you see automatically in your mind on this circle. And the impulse is starting from SA node, goes straight towards lead 2. So all the impulses are complexes are very positive in lead 2. So if you want to study P wave or QRS or T complexes, lead 2 is very good. And in V1, P wave is biphasic, as I've always said, and you can separate the right and the left atrial components. So it is very important for interpreting the changes, left atrial dilatation, right atrial dilatation, or biatrial dilatation, or atrial MIs. So in atrial MIs also we have to look in V2, V1, V2, and other leads also. And I will be covering some slides from the previous videos also, lectures also, because we can't rush through, because I got a request to make a video on exam oriented ECGs which are important from exam point of view. But ECG is something like maths, and I can't tell you that this question will come that 2 plus 2 is equal to 4. It could be 2 plus 3 is equal to 5. So that question might come. So, but if you know how to add the things, and then it's not a problem. You can be given any question and you will be able to answer. So there's nothing to by heart in the ECG. You can just know the basics and it will be fine, and you can be a master of the ECG. So we are starting with the pacemaker. These guys are pacing this lady, and pacemaker sets the pace of the race or the game. And likewise in our heart, ECG SA node is a pacemaker. So we are pacing each other and running, and so that is it. This is an interesting ECG. So this is J point elevation, and you see this in hypothermia. These are interesting ECGs. So I've just collected and made a compilation of these. So this is J point elevation. They are called Osborne waves, and you will see in hypothermia, and degree of hypothermia is proportional to the elevation of the J point. So you can see this is the ST elevation, the J point elevation. Okay, and it is very important to know that QRS complex is a sum total of the electrical activity of the left ventricle and the right ventricle. And it's not like over V1, V2 only right ventricular electrical impulses are shown, and over V5, V6 the left ventricle impulses are recorded. No, the right ventricle is recorded in the lateral leads also, and the left ventricle is recorded in the V1, V2 also. So it's like that. So whatever lead is over whichever ventricle, it will record a positive wave. Right ventricle is small, it is not very bulky, small r in V1, V2. Left ventricle is very bulky and it has to pump blood into the whole of the body. So it is bulky, more of myocardium, more of electricity being produced. So you will get a tall R in V5, V6. But in that case, impulse is going away from V1, V2. So you will get a deep S in V1, V2 when when we are talking about left ventricle. Okay. So this is also, everything is important from exam point of view. So I felt very bad when I was deleting some of the slides from my previous lectures because I had to make a compilation of the ECGs. But still I couldn't help keeping some slides from the previous lecture because they're very important. You can get an MCQ on this. So P wave denotes what? What is QRS complex? What is T wave? Okay, so P is atrial depolarization, QRS is ventricular depolarization, and T wave denotes ventricular repolarization. So you can be asked a question, where is the repolarization of the P waves of the atrium seen? You cannot see on a normal ECG because the QRS is forming during that time. So LV is very bulky, RV is also bulky, so it dominates the production and recording of the atrial electrical activity during that time. Okay, so you won't see the atrial repolarization leads complexes. Now this is a normal ECG. We have to know normal, only then we can go to the abnormal. Okay, in AVR everything is inverted. P is inverted, QRS is inverted, T is inverted, and in lead 1, V5, V6, and you will see tall R because they are lying over the left ventricle, free wall of the left ventricle, the lateral wall, they are very bulky, and you will get good complexes. Lead 2 has the tallest R wave amongst the first 6 leads in a normal ECG because the vector is directly directed towards from the SA node towards plus 60 degree. Lead 2 is placed at plus 60 degrees. That's why we have to come back to the circle again and again. Lead 1 is at 0 degree, AVF is at plus 90 degree. Okay. So you see this. So SA node has fired and it is coming directly towards lead 2. So that is why lead 2 records a very good P wave, very good R wave, very good T wave, and always remember T follows R. If this rule is not obeyed, something is wrong in the ECG. If R is tall, T is flat, T is inverted, T is biphasic, it is some electrolyte imbalance, could be hypokalemia, could be hypocalcemia, could be digitalis effect, could be digitalis toxicity, could be ischemia, ischemic changes, could be LV hypertrophy with strain, could be HOCM, and the LBB, the list goes on. Okay, so T follows R. If T is tall, you have to have a good R. Good. If R is good, T has to be good. AVR, everything is inverted. If something is positive in AVR, if especially the ST is elevated in AVR, something really bad is happening in the ECG. Maybe there is an inferior MI occurring, bad MI occurring, and it's very fatal, and maybe there is an anterior MI occurring during that time. Now there is a posterior wall MI. So whenever you have a patient with inferior wall MI, you have to look for right ventricular infarction. So you can record the leads on the right side of the chest. Normally we record the leads on the left side of the chest, but to see the RV changes will be visible in V3R, V4R. So similarly, you can record V1R, V2R, V3R, V4R. V3R and V4R, they are more important for diagnosing right ventricular infarction. Okay, and because V1 and V2 also record some part of the right ventricle, but the majority of the part of the right ventricle is outside the domain of the recording area of V1, V2. So that is why you need a V3R, V4R. And likewise for posterior wall changes, you can see the changes in V1, V2, mirror images. And what we mean by mirror images, you will see a tall R, ST depression, and upright T. If you invert it, R becomes Q, depression becomes elevation, T becomes inverted. Okay, so it's a very interesting finding. But if you want to record a true posterior wall MI, you will have to take the leads posteriorly, V7, V8, V9, V10 on the left side posteriorly. Okay, so this is something important you have to know. MCQ can come from this point of view. You can also get an MCQ on this. What is this? Tell the importance of this. So this is a picture showing calibration, and calibration has to be properly recorded. Every machine is programmed to record a calibration, and if the calibration is not there, you may ask for a calibration before interpreting the ECG, because if it is not 10 small squares in height and the plateau is not vertical and it's not falling vertically, you can get a false R or a false S or a false Q wave. Okay, so a patient with MI, there could be a recording of a R wave where there was a Q wave. So it's that important. And sometimes, like in lead, this first complex out here, you see it is just 5 small squares. So in this person's ECG, if R wave is in any lead, let's say V5, if the R wave is 20 small squares, actually the R wave is 40, because this is 5. We have to calculate for 10. So you double. Okay, so it is very important. Now you see in this, okay, we'll skip this one. So these are the normal durations. We know one small square is 0.04 seconds, and one small square in height, that is a voltage we calculate, 0.1 millivolts. So 10 small squares is 1 millivolt. That is important. And there are 5 small squares in one big square. So one big square is 0.2 seconds. Why this is important? Because if you have to calculate the heart rate in atrial fibrillation, you have to calculate for 6 seconds or 10 seconds and multiply by 60. Whatever, we have to calculate into for 60 seconds, because in atrial fibrillation R is irregular. So you cannot say, if you calculate the RR interval in one or two complexes, it will be different from the next two on the next two. So in that you have to calculate for a series of squares, maybe 6 seconds, all the R's you calculate and then you multiply by 60. So this is also important slide. I couldn't help keeping it. Rate, rhythm, axis. You have to calculate the heart rate first, the rhythm and the axis. Till you calculate this, don't think about MIs, don't think about bundle branch blocks, because otherwise the finer things in the ECGs you will miss. So rate, rhythm, axis. So we have covered all this. This is a normal P wave and a QRS complex and a T wave. Excuse me. So these are all the normal complexes. So you have to remember, in AVR, all the complexes are inverted. If something is elevated in AVR, it is something is wrong. Let us say P wave is upright in AVR. It means the P wave is coming from somewhere from below, maybe from the AV node. The AV node has fired to stimulate the atrium. So it is going towards AVR's positive pole. So AVR's positive pole is at minus 150 degree. So that is why for AVR, P wave becomes upright. For the rest of the complexes, it becomes inverted. And also you have to keep remember this thing for dextrocardia. I will discuss that later on, because in that too becomes lead 1 becomes AVR, AVL becomes AVR, 2 becomes 3, and there is a RAD. So that will come to later on. And sometimes the leads can be wrongly placed and you will get an upright QRS complex in AVR. So in a normal AVR, everything is inverted. You have to remember this. So this is how you take the ECG, and this is the transition of R waves and the S waves from V1 to V6. The normal transition zone is between V3 and V4, where R becomes taller than S. In V3 you see R is small, S is deep, and out here R has become taller than the S wave. So this is a normal transition zone. So there is a counterclockwise rotation and a clockwise rotation. We have discussed that in the previous 2 or 3 lectures. And this is also important. You can get a short note. Why is a small Q wave in the lateral leads normal? V6, lead 1, AVL. Why is a small Q wave? What is it because of? And why is it normal? Because the small Q wave in V6 or lead 1, it denotes the depolarization of the interventricular septum. So it has to be there. Normally it should be there. And if it is not there, maybe there is a MI occurring. And if it is very bulky interventricular septum, hypertrophic interventricular septum, you will get a deep Q in V6, which will simulate an MI, actually when there is no MI. So that's why it is very important. So this is the normal axis. So axis is directed from SNO towards lead 2. So tallest R you will get in lead 2. So this axis determination I have told you in the previous lecture, but I will just rush through. If it is between 0 degree and plus 90, it is normal axis. If it is between 0 and minus 90, it is left axis deviation. If it is between 0 plus 90 degree and 180 degree, it is right axis deviation. If it is between 180 degree and minus 90 degrees, it is extreme RAD. Some people call it extreme LAD, which you see in certain congenital heart diseases or very badly destroyed lung. Okay, so this is very important, and this is the electrical way of saying the quadrants of axis deviation. From clinical point of view, up to minus 30 we take it as normal, up to plus 120 we take it as normal. So this is also important. You can get a short note again on this. What is the normal axis zone clinically considered as? So you will write up to minus 30 and up to plus 120 degree, the axis is considered normal. If it is beyond minus 30, beyond 120 degrees, then it is abnormal. So how do we determine the axis? I had told you in the previous lecture. So you see lead 1 and AVF. If lead 1 is positive, AVF is positive. It is between, you will plot lead 1 positive out here, AVF out here, and it is lying in this quadrant. So it is the normal quadrant. And in this situation, the tallest R will be the axis. This I call it as James law, because this is my observation, and tallest R will be the axis if 1 and AVF are positive. Okay. But you should remember, none of these methods, they are infallible. The more these methods are positive, the more the chance that you will be right in determining the axis. And the great fun is that you should be able to say this is not 60 degrees, it is 62 degrees. So this is how we calculate axis on our rounds with my JRs, and it is big fun. And it gives a real kick because you are as right, as accurate as the computer. So this is the third method, and if not, then look for the most isoelectric complex, and perpendicular to that will be the axis. Now let us say lead 1 is isoelectric and lead AVF is positive. Okay, so lead 1 is isoelectric, so axis has to be perpendicular to that. So it means it could be minus 90 or plus 90. And then you look in AVF. AVF is positive, so it is plus 90. AVF is negative, it is minus 90. How do you say it is positive or negative? You divide, you minus R from S or S from R, whichever is bigger. Then now see, this is a normal axis, but why is it a normal axis? So lead 1 is positive, so you minus S from R, it will be still a positive result. Okay, see AVF, there is no S wave, so it is positive only. So positive, positive, it is between 0 and plus 90 degrees. And then the axis is, you can apply James law, the tallest R without S wave. So that is plus 60 degrees. So that is the axis. Then there is a fourth method of finding the axis. You can draw a rectangle along the X and the Y axis. So let us say, we'll see in this example only. Lead 1 is, let us say 5, 6, 7, 8 small squares. And this is 5, 9 small squares. So you draw a rectangle. Okay, so you lead 1, that circle you remember, along the positive side of the lead 1, 0 to center of the circle, you draw small equidistance marks. Okay, let us say 1 millimeter marks. So you draw 8 or 9, whichever is the answer, and 8 or 9 for AVF. And you draw a rectangle, and the diagonal of that will be the axis. It will be very accurate. Most of the times you will hit the right answer. But sometimes this diagonal method, you might be little away from, let us say by 3 or 4 degrees. Then we will use the tan theta method. So I'll show you the tan theta method. These are some more observations which you should know. The tallest R is the axis if 1 and AVF are positive. V1 and V2, they will be opposing V5, V6 electrically. If something is positive in V1, V2, deep S you will see in V5, V6. Something is very tall in V5, V6, deep S in V1, V2, like that. Similarly, inferior leads oppose the lateral leads. So AVF, lead 2, lead 3, they will oppose lead V5, V6 and AVL. Okay. And QT is inversely proportional to heart rate. If heart rate is more, QT is less. So you will see in hypocalcemia, quinidine toxicity and things like that. And if R is tall, T has to be tall. So these are some observations, and keep it in the back of your mind. And whenever you read the ECG, you calculate the axis or something, you should remember these things. Now find the axis in the next ECG. Let us find the axis. So you see in lead 1 is positive. There is no S wave. Okay. And okay. Lead 2, very tall. So very tall, it is very positive. Lot of current is coming towards lead 2, right from SNO to lead 2. Lead 3 positive, no S wave. AVR, AVL, AVF. AVF is also positive. So what is the axis? James law, 60 degree. Okay. Now here is the catch. So we are around plus 60 degree. Now how you will calculate? You will refine your answer. If you say 60 degree, you will get full marks. But if you see R of lead 1 is very tall, positive, no S wave, but R of lead 2 is even more tall. Okay, it is almost double the R of lead 1. So I will add around 4 degrees more. Okay, so I will say it is not 60 because lead 2 is pulling the electrical vector towards itself, towards the right side. Okay, towards the RAD side. So it is from plus 60, it is pulling like this. So this actually we had discussed on rounds, and we were accurate. I had made a diagnosis, and even my GR had made a diagnosis of 64 degrees, and the axis was actually 64. So you can see this answer, and out here you see the P wave axis, QRS axis and the T wave axis. The answer was 64 degrees. So you feel really great when you diagnose and you are as accurate as the computer. Okay, so this is Dr. Saurav, and he had taught me the tan theta method. So I always show his picture whenever I discuss the tan theta method. So in tan theta method, what you do is, let us say our lead 1 is positive and lead 1 is, let us say 2 small squares. Okay, and AVF is 4 small squares positive. Basically 1 by 2. If you divide 2 by 4, it is 1 by 2. So we have to calculate this theta, this angle. Okay, and it becomes a rectangle. You divide that, draw a diagonal, it becomes 2 triangles. So for this triangle, AVF is giving the value of height of the triangle. This is the height. So this is the height of the triangle, and this becomes a base. Lead 1 becomes the base. So tan theta is height by base, which is equal to 2 by 4 equals to 1 by 2. So tan theta equals to 1 by 2. So theta equals to tan inverse. You can open your calculators and interpret a few ECGs. It is big fun, and you will be as accurate as the TMT machine. So theta equals to tan inverse height by base. Okay, so you get the accurate answer. So you will be just 1 or 2 degrees here and there. That will be also because you are drawing with your hand just the equidistance arrows, marks on the lead 1 and AVF. If you use a foot ruler, you will be accurate. Now, anterior MIs will cause right axis deviation. Inferior MIs will cause left axis deviation. More so, lateral MIs will cause right axis deviation. So you have to remember this. Now look at this ECG. So what all things you see? This is a sort of isoelectric complex lead 1. This is called a VPC. There is no P wave preceding this complex. This is a broad QRS. T is inverted. Okay. What you should know about VPC is the polarity is usually changed. So if there is a R wave or whichever is a taller wave in that complex, the VPC will be inverse of that. Here there is a deep S, you are seeing a tall R. Okay, so this is a ventricular premature complex. You can get this because of some myocarditis or some dilated cardiomyopathy, or because of consequence of scarring of the myocardium or sclerodegenerative disease, a lot of things can cause a VPC, drugs. So this is a isoelectric line. Let us say this is isoelectric lead 1, lead 2 is positive. Okay, no S wave. Lead 3, no S wave. So AVR, this is AVR, nothing is positive in AVR, nothing is elevated, so fine, good. So AVL and AVF. Now see, of the first 6 leads, I think only lead 1 is you can classify for the isoelectric complex. So what is perpendicular to lead 1? Minus 90 or plus 90. Now look in AVF. AVF is positive, it is not negative. So in that circle, we'll place AVF at plus 90. So it is a right axis deviation. Now you should think, once you have rate rhythm axis like that. Always think like that. Now axis has deviated to right side. Now let us find the cause of RAD. Look in V1 to V6. There is no progression of R waves from V1 to V3. Q wave, Q wave, Q wave, V1, V2, V3. So Q wave, Q wave, Q wave. So this is anteroseptal MI. So maybe this is a recent anteroseptal MI. What else you will see in the ECG? I can't say only the MI changes. We have to interpret the ECG in totality. So this is a VPC, VPC, VPC. Here see, this is a positive R, VPC is a negative. VPC is negative. Okay. Then this is ST depression and T is upright. So these are the findings. Okay, so you cannot miss all the findings because you can be given any ECG and you just can't say this is anterior wall MI. There might be first degree AV block in that, you will get marks deducted for not saying that, or early HB or some other finding might be there, or a interventricular conduction defect. So you have to answer everything. So what you should do when you interpret the ECG is look at the calibration, then complex wise you go. Okay, you see the P wave, SA node, P wave, atrium, what all things can happen at atrial level, then the AV node, then the bundle branches and the ventricles. Okay, so like this, so you divide and look for the things in that particular area which can cause that finding. Now this is indeterminate axis. Okay, so R equals to S roughly. Almost in all the leads you are seeing isoelectric complexes. So this is termed as axis is indeterminate. You cannot comment on the axis. And what else is there? We can't just limit ourselves to axis interpretation in this ECG. We have to find something else also. Okay, so we'll go ahead. So P looks little broad to me out here. It is more than 3 small squares maybe. Now P is broad, so the distal end of the P wave is found by the left atrium, and that is broadening the P wave in lead 2. Now I will look in AVF. Okay, so in AVF you see P wave is biphasic in V1. So in V1, see, positive component is small. There is a deep negative component of P. So this is left atrial dilatation. Okay. In atrium, you will never say left atrial hypertrophy because there is hardly any muscle in the atrium. So you always call it left atrial enlargement, left atrial dilatation. And what else is there in this ECG? Rate, rhythm axis, P waves you have seen. See the QRS. There is a RS-R dash pattern. RS-R dash pattern with ST depression, T inversion. So this is a right bundle branch block. Now look at the QRS duration. QRS is not fully like more than 3 small squares. So it is an incomplete RBB. It is not a complete RBB. It is an incomplete RBB. Okay. Now what else can you find? You have to be like Sherlock Holmes when you interpret an ECG. There is a hidden finding in this. So tall R in V1, V2. There has to be deep S in V5, V6. It is there. Why there is a tall R in V5, V6? Maybe there is a left ventricular hypertrophy also, and electrical axis is changing, so you are not seeing a very deep S in V1, V2. So how you will confirm this? You can do an echo. Echo will show you the myocardial ventricular thickness, and it is the diagnostic test. Now in this RAD and RBB, so isoelectric, 2 positive, 3 positive, you should keep on commenting in your mind on all the changes. So I see a interventricular conduction defect, this notching, interventricular conduction defect. Whatever doesn't fit in any of the terminologies in the ECG, we just label it as interventricular conduction defect of the QRS complex. Okay. So this is interventricular conduction defect. AVR all inverted. So far so good. AVL and AVF. So what is the axis? Isoelectric. AVF is positive, plus 90, right axis deviation. This is a right bundle branch block. Okay. So this is a complete right bundle branch block because it's broad, more than 3 small squares, RS pattern, concavity upwards depression, ST depression, and T wave inversion. Okay, so this is a right bundle branch block causing right axis deviation. So what is the complete criteria for right bundle branch block? R for right bundle branch, right axis deviation, and tall R in V1, V2, deep S in V5, V6, ST depression, concavity upwards, and T wave inversion. Okay, and okay, so LV we will discuss later on. I couldn't bypass any of these ECGs because they are very interesting and very important ECGs. So it shouldn't hurt to go through these findings again because this is what you will get in the exams, and these are the findings, and you will get these only. So the ECG might change, the patient might change. That shouldn't bother you because by then you will be masters in ECG and you will be able to detect. Now see this ECG. Spend 2 minutes on this, please, and please comment in the comments live chat what the finding is. So I cannot see the live chat going on because I am using the webcam. I'm using the phone as the webcam, and that is why the resolution has improved. So on the screen the PowerPoint is open and my OBS is minimized. So I'm just presuming that video is going on fine, the live stream is going on fine. I know it is going on fine because Eric is sitting there and he supports me and always keeps on telling me the audio and any other problem if it is there. So thank you, Eric. Now say in lead 1, positive. Axis is current is going towards lead 1. Okay, towards 0 degree. Axis is around there, 0 degree. Now what do you expect in lead 3? It is going away from lead 3. That is why it will go towards lead 1. Okay, so lead 3 should show an S wave. Okay, then you see in AVF, it is a S wave. Now you will say, sir, this is a Q wave. Okay, some experts will say this is a Q wave, maybe it is a Q wave, but out here there is a notching. A small notch makes it a R wave, and then the next negative wave is the Q wave, S wave. If the negative wave is before the notch, then it becomes a Q wave. So if Q wave is this deep, it is a pathological Q wave. Then QRS, R and S should follow after that. Okay. So what is a pathological Q wave? If it is more than 1/3 of the R wave and it is more than 0.04 seconds in duration. So that is a pathological Q wave. Now what else is there in this? So positive, AVF is negative. So there is a left axis deviation. Okay. So there is a left axis deviation. Now we look in V1 to V6. There is a loss of R wave progression. There are Q waves, V1 Q, V2 Q, V3 Q wave, V4 also Q wave. So this patient has had an anterior wall MI. Now I said that anterior wall MI will cause right axis deviation, but here left axis deviation is occurring. Okay, so how can we explain? So you look for other things which can cause left axis deviation. So this is a S wave, this is a S wave, and there is a small s in 2. So it's not a very good left anterior hemiblock, good for the patient. So any left-sided changes, they are more powerful. Left bundle branch block, left anterior hemiblock, they will overpower the right ventricular changes. Okay, so this is a left axis deviation, but there is a anterior wall MI. Okay, so like this, you can have variation, aberrations in the concepts. So ideally, anterior MI should have caused RAD. But if it is more of lateral MI, then the axis will definitely change towards the right axis side. Now this is a very good ECG. So you see in this ECG, lead 1 is negative, R is small, S is deep. Okay, so S is deep, lead 1 is negative. We plotted at 180 degree, that circle. The negative component of lead 1 is at minus 180 degree. So AVF is a very positive, good R wave in AVF. So negative AVF is at plus 90 degree, it is a right axis deviation. Okay, right axis deviation. Now what is the cause of right axis deviation? Let's find the cause. So small r, good r in 3, AVR everything is inverted, there is no junctional rhythm happening right here. Okay, because P is inverted, P wave is inverted in lead AVR, so there is no junctional rhythm happening. That is how your brain should be just analyzing and making conclusions while you're just looking at the ECG like that. AVL has a small r, or maybe it's a Q wave, okay, but lead 1 has a R wave. Definitely this is R wave, and out here there is a good R. Now we come to V1 to V6. Now what do you see in V1 to V6? There is a very tall R in V1, V2, V3, V4, V5, V6. Tall R's. So much so that there is slight curving and T inversion. Okay. So now here you will have two differential diagnoses. One differential diagnosis could be NSTEMI, and the other differential diagnosis could be right ventricular hypertrophy with strain pattern. I will go with RVH with strain pattern. Okay, because if it is an MI, the amplitude of R cannot be this high, and this is a very good R wave. So our right ventricle is very bulky right here, and that is why more of electricity is being produced, and there is a repolarization defect which is inverting the T wave, and that is it. This is an RVH, and also there is a LVH. So this is a biventricular hypertrophy. Maybe this patient has Hockham or very severe hypertrophic concentric LVH, and even the right ventricle is hypertrophic and interventricular septum is hypertrophic. So like this you have to analyze the ECG, and it becomes very interesting. So out here you see electrical rotation of the heart. So this is a counterclockwise rotation. When you talk about rotation of the heart, you're looking at the heart from the foot end of the patient. Patient is lying like this in front of me, and I'm seeing the heart rotate. The heart of the patient is rotating like this electrically, because the R has become taller than the S wave in V2 to V3. The normal transition zone is between V3 and V4. So this is a counterclockwise rotation. You can just keep on making small points, and this video will be there live or online only, and you can always come back and interpret. Now this ECG, you see, it is very interesting ECG. All the ECGs are interesting. That is why I didn't feel like deleting any of it. So maybe we'll split the lecture into 2 or 3 lectures, and even if your batch is changing from tomorrow, you are always welcome to join the medicine classes, and these lectures will be there, and feel free to come back, and if you have any queries you can just WhatsApp me or leave a comment and I'll answer them or make a new video. So lead 1 is positive out here. Lead 2 IVCD, interventricular conduction defect. Lead 3, yes, there is a Q wave, there's a curving. Now you come back, reorganize your thoughts. Yes, this is curving, T inversion. AVF, curving, T inversion, Q. So this is a recent inferior wall MI. Maybe it has not fully evolved also, and there is curving. Curving is a sign of acute injury taking place. Trop T might be positive at this stage. Now this one, lead 1 is isoelectric, AVF is positive, there is the interventricular conduction defect out here. So causes of right axis deviation, one is right bundle branch block, look for it. RS pattern, concavity upwards, T inversion, ST depression, and T inversion. Okay, so this is a right bundle branch block and some IVCD. Just a sec, guys. Okay. So please leave a comment, because if the camera is on or not on. And Eric just told me the camera is not on, because I'm just experimenting with the softwares and the cameras and all. And abhi aa raha hai camera, Eric? Camera aa raha hai? Okay. So everything is fine. Now you look at this ECG. Okay. So lead 1 is negative. Yeah. So guys, we'll just take a short break, and we'll come back soon. Okay. Just 1 minute break. I'll fix the camera. Okay guys, we are back, and I had to take a small break because the camera had switched off. I don't know how. So these are all the part and parcel of the process. I'm just learning how to use the software. It's very complicated, but it's a freeware OBS software. So if you want to stream, it's very good. You can open multiple windows. You can stream the browser. You can stream a lot of things. You can stream videos, songs, and PowerPoint slides, and a lot of things. And thanks to all the programmers who made OBS. Now you see out here in lead 1, it is negative. R is smaller than S wave. Lead AVF is positive. So lead 1 is at 180 degrees. AVF is at plus 90 degrees. So it is right axis deviation. Okay. So what is the cause of right axis deviation out here? Now there is no right bundle branch block. There is no RBB. Why is there a right axis deviation? Now you see in V1, V2, there is a tall R with T inversion. Okay, so that is right ventricular hypertrophy. So that is why there is a right axis deviation. So there is always a cause of axis deviation, because axis is normally not deviated. So SA has fired and it goes straight towards lead 2 plus 60 degree. So that is the thing. And supposing the patient has right axis deviation, and this patient comes to you with chest pain, frothing, shock, and other things, and he is a follow-up patient. He had TB, and he has a destroyed lung, and that is why he is a right axis deviation. And it was at let us say 92 degrees, but now the axis is at around 150 degrees. So there is a more right axis deviation, and that will be, you have to consider pulmonary embolism. So whenever the axis deviates to right, so you have to consider pulmonary embolism. Beast. No, no, no. Sorry guys, my dogs are my dogs are here too. Roman and Beast. Now he's trying to climb the chair. Na beta. Say hello. Say hello. So these are my Roman and Beast, if you can see them, but they might just spoil the apparatus. Eric, ध्यान रखो इनका. Okay. So I'll wind up after 1 or 2 slides, guys, because my dogs are also getting restless and you might be saturated by now. And it was a very productive session today. And we'll just end it here. And it was nice. This intrinsic deflections, MIs, and further left ventricular hypertrophy, right ventricular hypertrophy, and AV blocks, first degree AV block, Mobis type 1, type 2 complete heart block, and IVCDs and intrinsicoid deflections, and pre-excitation syndromes, WPW and LGL syndrome. All these things we'll discuss in the next session. And there are other things also which I have to show you, all the electrolyte abnormalities, hypocalcemia, hypokalemia, hyperkalemia, and it will be futile if I just put them in one lecture. It will not make sense. I'll get tired and you'll be listening in a boring mindset and it won't bring us results. So I think today we'll wind up here only. Thank you guys for coming and watching, and please do subscribe if you haven't subscribed, and there's a bell icon here, so please hit the bell icon and it will remind you whenever I go live or I upload any video. And also do comment, leave the comment in the live comments. And this is Beast and this is Roman. So thank you guys, and stay happy, stay blessed. God bless you all. Bye bye.